Our second speaker for the day is Mrs. Vidya Lakshmi, a senior embryologist and lab manager at GarbhaGudi IVF Center with a strong educational background in biomedical sciences and clinical embryology. She is a highly qualified and experienced professional in her field. She has been instrumental in conducting numerous webinar and CME talks where she has shared her knowledge and insights with the peers and her budding embryologists. Vidya Lakshmi's dedication to her work, passion for research, and extensive experience make her an valuable member of GarbhaGudi IVF Center team. Today, Vidya ma'am will be giving us molecular knowledge, that is molecular PGT or PGD analysis. Over to you, ma'am.
Thank you so much. Happy evening, everyone. Today we are going to talk about molecular PGT analysis. So pregnancy with genetically affected child. So it will be a traumatic, emotional, social, financial trouble. Many religious or social issue also is against abortion. So this is a general terminology we generally know and everyone are aware about. So is it possible to screen embryos for genetic defects prior to implantation so that we'll avoid some traumatic or emotional and other financial or religious social issues related to abortion? So is it possible if we can see that we implant a healthy embryo and we get a healthy pregnancy? Yes, it can be done with the help of PGT. So previously, this PGT has been explained or has been known by the name Preimplantation genetic diagnosis. So it is known earlier as PGD and also as PGS, that is for pre-implantation genetic screening. So there were two terminologies existing earlier, PGD and PGS, which has been replaced recently as PGT in a single terminology known as pre-implantation genetic testing, which involves both screening as well as diagnosis. So following a revision of terminology used in healthcare. So nowadays it is used intensively in infertility care as PGT. So what is PGT? It is defined as a test performed to analyze the DNA of a oocyte, so a polar body from a polar body or embryo that is in a cleavage or a blastocyst stage for determining genetic abnormalities. So this also include PGT for aneuploidy. So if you want to go and test aneuploidy, it is called as PGTA. And if you want to test monogenic or single gene defects, it is termed as PGTM. M is for monogenic or single gene defects. And PGTSR, this terminology is for structural rearrangement of the chromosome. So we have three PGT. We have PGT, in that comes PGTA for aneuploidy, M for monogenic or single gene defects, and SR for structural rearrange. So the decision to accept, that is like who wants to go for PGT or who doesn't require to go for PGT, the sole decision will be with the healthcare provider. So the healthcare professionals there, either gynecologist, genetist, or embryologist who is working in the infertility care. So PGT request should be compliant with national legislation. So it depends on which country you are in and how is your national or ethical board. So whether PGT is allowed in your country or not. So depending on that, it can be provided. So going on to the principle of PGD. So what is principle? How does it work? PGT allows healthy embryos to be distinguished from that of affected. So we need to know in embryonic stage which is the healthy one, which is the affected one, so that we can differentiate the healthy one from the affected one and give a healthy pregnancy. So this is the core principle of PGT. So prefer transfer of genetically normal euploid. So how do we know a normal euploid? When we perform PGT. So this normal euploid will provide high probability of healthy pregnancy. Also, it will avoid prenatal diagnosis and termination of pregnancy. So we don't want to end up in a trauma for the prenatal diagnosis, and if in case something is not going well, we have to terminate the pregnancy. So all these criteria can be avoided if we go ahead with PGT. So generally, usually what we do, traditionally we select embryos based on the morphological criteria. That is, if it is a 2-cell stage, how it is dividing, how the proportion is, how the morphokinetics is. So based on the morphology, like how we see the embryos, we select the good ones or the not good progressing ones, and we implant them in the uterus. But we cannot see whether it is a euploid embryo or an aneuploid embryo. For this, we have to go for another test, that is what PGT is, additional genetic screening. So underlying principles of PGT, if you see underlying principles. So if we do, what do we get? Improved delivery rate, reduce spontaneous abortions, reduce aneuploidy conceptions, and also increase the implantation. So aneuploidy will give you miscarriages also. So we increase the implantation. So indications for PGT, for PGTM, for couples at high risk for transmitting a specific gene disease for the offspring. So who are at a high risk for transmitting the disease? Single gene disorders. If they are suffering from single gene disorders, carrying mutations like breast cancer gene, for HLA matching in case of anemia, or chromosomal structural rearrangement, that is like balance translocation or inversion, those kind of cases also can go ahead with PGTM. So what all documents we require if we are going for PGT? So do we require any other additional documents before going to PGT? So original copies of the result of genetic testing needs to be there. Karyotyping needs to be done prior, and those documents need to be present. And specific testing of the index patient, the spouse or partner or child or the entire family member is needed. And female reproductive history, gynecological and fertility status is needed. Male reproductive history also, and andrological history and fertility status, sperm analysis report, everything is necessary. Report on health problems, any other health problems of female and male partner, whether it is genetic health issue or related to IVF and pregnancy should be mentioned. And for PGTM and SR, a genetic counseling report should be there. Report together with full pedigree analysis of family data should be there. So PGT workflow chart. So how does the workflow happen? First, couple come for consultation, and then we go, we send them for pre-PGT workup. So they'll go there, and everything will be screened, like pedigree chart and everything. So once that workup is done, they can go ahead with IVF cycle and a blastocyst biopsy preferably. After that, the biopsy sample will be sent for the analysis, that is for the genetic testing. So once the report is out, embryo transfer can be done. So 3 types of pre-implantation genetic testing, as I have already mentioned. PGT-A. So it is for aneuploidy. So only when we are suspecting the aneuploidies and we want to test the aneuploidies, we send the patient for PGT-A. So this test determines whether the correct number of chromosomes are present in the embryo or not. So only the correct number is present or not will be determined by PGT-A. Then moving on to PGT-M, that is for monogenic. Only when we suspect something in the family history or inherent genetic cause, we send it for PGT-M. So this test screens for single gene disorders such as cystic fibrosis, BRCA1, 2, and Huntington disease, like that. Then moving on to structural rearrangement. Also, when we see a structural rearrangement in the parents, we counsel them for PGT-SR. So screenings for chromosome rearrangement like chromosome inversion, translocation, everything can be found out when we send the sample for SR. So when we send a sample for PGTA and we want to determine the translocation or inversion, it will not be done. So a PGTA corresponds only the presence of correct number of chromosomes will be determined. So you have to go for M if it is like you want to test a single gene disorder. So it should be sent for M. And if you are suspecting any inversions or translocation in the family history, and you want to screen that for the embryo, it should be sent to SR. So PGT for aneuploidies, PGTA. PGTA will now be used to describe screening embryos for sporadic chromosomal abnormalities. So you can send PGTA if you're suspecting multiple miscarriages or something where the karyotyping is normal for the couple. Also they are like undergoing multiple failures or miscarriages, we can refer them for PGTA to just see whether the chromosome have a normal competent setup or not. So PGTA refers to testing of embryos by counting 46 chromosome to look for extra or missing chromosome. So that is where we call them as aneuploid embryo. And PGTA is used to select embryos that are most likely to implant and result in a successful pregnancy. So it also reduces the chance of having a child with extra or missing chromosome. So such as Down syndrome and all can be found out, and we can rule out these category with PGTA. So when you see PGTM already, as I have mentioned, so used to describe a single gene disorder. So we can help individual or couple to reduce this risk of having a kid with an inherent or any mutated single gene disorders. And as in case of structural rearrangement, so we can see the balanced chromosome, that is structural, any other inherent hereditary genetic defects that is in the family can be ruled out when we go for PGT-SR. So when we find this out and when we find a normal embryo out of it, we can avoid the pregnancy loss or the genetic disordered baby and any other abnormalities related to this. So introducing to biopsy and sample collection. So how do we do the biopsy procedure? First and foremost thing is we need to select the embryo which we are going to send for the biopsy. So how many embryos are we sending and how many embryos have we got in this cycle? Then we have to open the zona pellucida, so the outer shell. So how can you see a shell of an egg? So the components are inside the egg. Outer is covered with a shell. Likewise, embryo is also covered with a shell. So it is called zona pellucida. You have to create an opening of the zona pellucida. Remove the embryonic cell from there. 1 or 2 cells we have to remove, or polar bodies also can be removed. So this zona opening can be either mechanical, chemical, or using laser. So as a general practice, first how we do, you can see in the PGD scheme, first there is a genetic examination of the couple. Then there is a conclusion whether, okay, what needs to be done. So after that, they go for the IVF, in vitro fertilization. Then we take few cells from the embryo. We create an embryo, take few cells, send it for FISH or PCR. So fluorescent in situ or PCR will be done. So based on the result, we will be going ahead with the transfer. So methods of oocyte and embryo biopsy. So if we see in the oocyte stage, in a zygote stage or in a oocyte stage also, we can do biopsy. So we can take the polar body if it is a day 0 to day 1 zygote or a oocyte. So day 2 to day 3, we have blastomeres. So the cells will start budding. They'll start developing into 2 cell, 4 cell, 8 cell, and so on. So we can take 1 cell and we can test. So it is called as cleavage stage biopsy. Then we have blastocyst stage biopsy, that is on day 5 or day 6. If you see, embryo will have more number of cells. So we can take few cells and we can send them for the testing. So steps in PGT. So first we are going to open the zona, remove the cell, then fix the cell, and then send it for the chromosomal analysis. And also embryo will be frozen for that cycle. So penetration or zona opening will happen mechanically, chemically, and laser. So mechanical and chemical is not very much preferred because they have their own effects. They will have a negative effect on the embryo also sometimes if not done properly. So the embryo will undergo stress and degeneration in many cases. So laser is very safe and effective and recent method which is used widely for biopsy. So this is a picture of a polar body biopsy. So what is polar body? They are byproducts of meiotic division, and these byproducts we don't require them for the embryo development. They protrude, they come outside, and then they degenerate. So these doesn't require for the successful embryo development in the later stages. So these are the byproducts. So we can take these byproducts of the zygote and we can test them. We can send them for the analysis. They will have the similar component of the embryo. Whatever the embryo have, the genetic makeup will be tested with the polar body also. So how do we do the timing? 1 or 2 hours after extrusion we can do. And if you see, typically first polar body will degenerate 10 hours after HC. So second polar body, if you see, they will be formed 2 to 4 hours after HC and they will last up to 6 hours. They will be firmly attached to the ulema or the spindle. Only we are going to just open sufficient space in the zona pellucida that is greater than 15 micrometer, or usually 18 to 25 micrometer will be a sufficient space for the needle to enter. So best time window, if you ask best time window for polar body biopsy, if we are going for a sequential, that is 4 to 10 hours after EC for the first polar body on day 0, or 8 to 16 hours after HC for second polar body on the day 1. Or if you want to take simultaneously both the polar bodies, we have to wait 8 to 10 hours after fertilization or HC, and then we have to take them out. So too early, if you're doing too early, it is very risky because of spindle. If you're doing it too late, first polar body will disintegrate. So the diagnostic failure will happen. So how do we do the polar body biopsy? First, you can see a zona, that is the circle ring outside. Center will be the ooplasm, and the small protruding thing outside the ooplasm, that is in the perivitellin space, is called polar body. So first we have to make a drill of the zona, enter inside, aspirate the polar body, and then come outside. So this is the typical representation of how we usually do. We are holding it with the help of a needle, and the biopsy needle will enter inside the zona and then aspirate the polar body, come outside. And this polar body will be tubed and it will be sent for the genetic screening. So moving ahead with the cleavage stage biopsy. So this we can perform this during kind of day 3 stage. So typically not when the embryo is going for compaction, before compaction stage and after 6 cell stage is very ideal to do the cleavage stage biopsy. So most widely practiced embryo biopsy and 90% of all reported PGD cycles, people prefer cleavage stage biopsies. And here you can see that we can create, the zona will be little bit thinned out than the polar body biopsy. Their zona will be thicker and the perivitellin space will not be there. Here you can see a good space around the embryo, so around the blastomeres. You can select one blastomeres, aspirate, pull it outside, and then you can tube it. So this embryo will be frozen for this cycle. So when the report is out, whatever the embryo is good, only that embryo we are going to thaw, take them to the blastocyst stage, and then transfer. So several methods can be used. First, what we are going to do, we are going to just remove a cell. Either we can fix them or we can tube them. So fixing will go for fluorescent in situ analysis, FISH, and tubing will go for PCR. So PCR is widely used and comparatively better. So we can go ahead with the PCR. So we can tube whatever cells we have got, we can tube them. So again, day 3 embryo biopsy, how we do? First, we have to hold the embryo, then drill the zona and hold the blastomere. Again, pull the blastomere outside with the whole aspirating needle. and then we can take it out. So we can fix it for FISH, or we can lyse it, put it in a lysis buffer and send for PCR. So again, a similar diagrammatic representation of the biopsy. So after biopsy, it should be immediately tubed, and we have to store them in the refrigerator -27, and then they should be transported. If we don't have a setup for a genetic screening, if we have a setup for genetic screening, it should be performed, or we should send it outsource. We can also outsource. We can send them for the genetic testing for the genetic laboratory. So how many cells to be removed? So typically 2 cells if more than or equal to 6 cells. So the efficiency of PCR needs at least 2 cells, and for FISH only 1 is enough. So timing of cleavage stage biopsy, what will be the correct time? So before compaction, anytime before compaction, when the cells are not fully merged and when they are distinctly seen. So it will be easy to take 1 cell out, or else the entire content might come inside. So we have to be careful selecting the time before intercellular adhesion or junction formation. And it will be less difficult and less damaging also for the embryo. We have to perform in the correct time. And also there is a doubt saying that if we remove 1 blastocyst, will there be any effect on the baby? Or if the baby will be normal, or any other, will it look normal? It will be totally normal, because the blastocyst or the blastomeres are totipotent. So they are not a baby yet. They are still in a stage of the development, and they are totipotent cells where they can generate multiple cells. Even one cell divides to 2 and 4 and 8 and 14. So they have the potential to form entire baby. So there will not be any issue even we take few cells out of them. So specific problems of the biopsy. So one such problem is mosaicism. So I will explain it in detail in the coming slides. And blastomere biopsy. So we'll also see the blastomere biopsy, and then I'll go for the result and how do we interrupt. So as the early stage, that is 6 cell tight junction will happen, and the embryos will go for compaction on day 4. So once they go for compaction, we get many cohesive cells formed. So you can see this is called a blastocyst. So outer is the zona, inside the trophectoderm, and the cohesive cell, inner cell mass is what we call. So the inner cell mass will become the baby, whereas the trophectoderm will become the placenta. So we can take a few placental cells, which will again regenerate, and then it will help in the implantation. There will not be any issue. So we are going to take the trophectoderm cells, and whatever the genetic makeup is there for the baby, that will also be in the trophectoderm cells, which is going to be a placenta. So we are going to take few trophectoderm cells from the blastocyst. Around 5 to 10 cells can be removed, and that will again regenerate, and it will implant, and it will be a normal process. And whatever cells we have removed, it is going to go for analysis. So this is how it will be. Blastocyst, we are going to make a hole with a laser. So we are going to cut the zona. So you can see the second image where how we have cut the zona there. And then we are going to pipette few cells, 5 to 10 cells in a pipette. So that will be again cut with the help of laser. And these cells will be transferred in a tube with a lysis buffer. And then it will be sent for the genetic screening. So this remaining blastocyst will be frozen on the very same day within 1 hour. And it will be kept safe until we get the result. So there is a video. So in this image, you can see, in this video, you can see that it is a blastocyst. So the red one is the laser optics. So there will be few shots given to the zona. So only the zona, we have given few shots. And then the needle goes towards the embryo. So the embryologist is focusing the embryo enough. And this is called the biopsy needle. So the embryo is already holded well with a holding needle. Now the biopsy needle enters the embryo, removes only the trophectoderm cells. So trophectoderm cells, I think 5 to 6 cells have been aspirated. And then now you can see that there are multiple shots of laser given. So there will be shots of laser given and the cells are dislodging from the blastocyst. So that's all. So now that embryo will be frozen and the cells which we have removed will be sent for the analysis. So which chromosomes are best to be analyzed? So X chromosome, Y 13, 14, 15, 16, 18, 21, 22. All these chromosomes are being analyzed for aneuploidies, most commonly in IVF centers because of spontaneous abortions. So we can analyze most of these chromosome sets with the help of biopsy. So you can see blastome here and polar body biopsy. So once we take the biopsy, we are going to send it for fluorescent in situ analysis, and this is how they will interact. Like they will tag, label the embryos, label the DNA, and then we can see where how the competent embryo is. And when we send for PCR, we know that it is a polymerase chain reaction. Even one blastome here we send, it has the capacity to multiply. So it will multiply to n numbers, and then again it will be tagged with the control, and then we can see whether there are any chromosomal abnormalities. And also there is a technique called array CGA. So in this technique also we are going to quote patient and control. Samples will be mixed, hybridization will happen, then DNA array will be done, and then we can easily see whether there are any duplication or deletion, anything. So this is all programmed and it will be done by the computer system. Only thing is sample will be loaded in the machine and it will analyze. And there is also a technique which we generally analyze, that is SNP, single nucleotide polymorphism, is a new technique that can examine all 23 chromosomal pairs. So SNPs are single bases. There are the building blocks of DNA, which can be a different sequence in a different individuals. So they can detect not only the copy numbers or the changes, but also can detect inversion translocation also can be done in SNPs. So generally, when we see a person will be healthy and normal, but they will be undergoing recurrent miscarriages. So we can suspect SNP in them, and it can be sent for SNP analysis also. So normal, which says carrier, and the deceased, there will be difference in the SNP, which can be found out when we go for SNPs. And the result, how the result will be for the PGT. So generally, we get result in 3 setup. One is euploid. So the normal embryo, everything is normal, comes as a euploid. And there is also a terminology called aneuploid. That is all, like entire embryo is abnormal. It will be having a defect or any chromosomal abnormalities will be present. So it will come as an aneuploid. And something which is very challenging is mosaic. When there are abnormal as well, when there are little abnormality in an embryo, so we can call them mosaic. There are the embryo is not totally abnormal, but there is few cells which is affected. So sometimes embryo have the capacity to rectify itself and give a healthy pregnancy. Sometimes it will not have. So this mosaic is a confused terminology in many cases. Like how do we proceed with the mosaic embryo? So should we replace the embryos or should we not replace the embryos when it is a mosaic embryo? So you can see there will be a single cell. When it divides, the error will happen in the second cell. So automatically, when the division happens, half the embryo will be normal, whereas some portion of the embryo will have the abnormality. So can we self-correct? Can the embryo self-correct and can it give a healthy baby? So what do we know about mosaicism is that if the mosaicism is present, that is less than 20% in an embryo, we can term it as a euploid embryo. So they have the capacity to regenerate. So when the mosaicism is 20 to 40%, we call it as low-level mosaic. And when it is 40 to 80%, it is called as high level mosaic. And when it is more than 80%, it is called as mosaic. So 20% we can transfer and we can get a healthy pregnancy. It will autocorrect. If it is a low level mosaic, that is 20 to 40%, we can transfer with the signature of the couple saying that they are willing to go for a pregnancy as a second or as a last chance for them. So if they are having any other healthy embryo, we can transfer them in a first choice. This can be kept as the last choice for the couple, and with their consent, we can transfer. And high level mosaic and aneuploidy. So this we should not transfer, as that will end up in having a probability of unhealthy baby. So laboratory issues related to biopsy. So when we are performing biopsy, everything should be clean, everything should be decontaminated, because even DNA can be mixed from the hair or from the nail or hand of the person who is working in the laboratory. So everything should be cleaned with the appropriate solution given. And PGT related procedures should be happening with a protective cloth worn so that we don't contaminate the content what we are sending, and everything should be sterile. Hair cover, hat and mask should be maintained, and gloves should be worn at all the times, and gloves should be powder free and well fitting. So what are the advantages of PGT? Embryo abnormalities can be ruled out, and we can reveal it prior to the implantation, and we can reduce abortion rates due to embryo, that is more than 1 or 2 abnormalities can be determined, and parent can select a healthy and qualified embryo to implant. So we can select the healthy embryo, so risk of abnormality decreases, and also pregnancy rates are increased to 60 to 80% increased, because we are cutting down the abnormal embryos. So aneuploidies or any other miscarriages risk is very less, and reduce the hereditary or genetic diseases from generation to generation. So chromosomal abnormalities increases with maternal age. So when we see when the couple, generally when the women is less than 35 years old, 25% is the risk for chromosomal abnormality. 35 to 37 years old, 36%, and 38 to 40 years, 49%, 41 to 42, 69%, and more than 42, 79%. So this is the increase of chromosomal abnormalities with the increase in age. So how old the age is for the female, that much risk is there to carry an abnormality in the gametes. So based on the age also, we should select. So what makes an excellent PGT center? How do we set up, and what makes an excellent PGT center? So we have to generally evaluate the couple. So who is recommended for PGT, who doesn't recommend, based on the history, based on the family history, based on the infertility history. Everything should be seen first. And then excellent genetic evaluation and counseling. Next is genetic evaluation. So how do we evaluate them, and how do we counsel them for the genetic analysis? And then excellent IVF platform. So you need to have a good IVF laboratory, IVF setup, and a platform where you can perform all these tests. And then excellent diagnostic laboratory. So diagnostic laboratory also you need to perform the genetic testing. So if you are not going ahead with a diagnostic laboratory setup, we can also outsource a good diagnostic laboratory who gives us accurate results. So there should not be any false positives or any mishandling of samples. So a good laboratory can be outsourced, we can give them. And then excellent patient experience. Patient experience also should be good for the center, and integration of services. So how well we integrate with the other services in the center, and rigorous quality control and quality assurance. So not that only we do the procedure correctly, but also we have to every time look into the quality control and assurance inside the laboratory or inside the clinic should be taken in care of. Also, commitment to follow up or comprehensive ethical review. So how do we follow up with patient? How do we follow up with the case? And how do we go it ethically with the government or with the setup of your country? So that is also to be followed. When we follow everything, it makes an excellent PGT setup in the center. So thank you very much. We have come to the ending of the session. I hope it was informative too. Okay, there is one question. Can these tests be performed in normal pregnancy? So what do you term it as normal pregnancy? Not an IVF, but a normal pregnancy? No, we cannot perform PGT in a normal pregnancy because we are testing embryos. When you call it as a normal pregnancy, the embryo is already implanted. So we cannot test in those scenarios. We can do PGT analysis only in IVF cycle, not even in IUI cycle. It will be done only in ICSI or an IVF cycle. You have to retrieve the gametes outside and then it should be performed. Normal pregnancy, we cannot perform.
Thank you, ma'am. Your talk was an absolute delight. Your passion for the topic was contagious, and your approach to sharing your insights kept us on the edge of your seats. Thank you, ma'am. Now we are open to question and answer sessions. You can drop your queries in the chat box.
There is a question in the chat box. How much we got diagnosis of genetic disorder by double marker and triple marker test? I'm sorry, I couldn't understand the question well. If it is related to PGT is better or these tests are better, whether the question is about which is better, then definitely PGT is better because before the implantation, you'll analyze the entire setup, the entire chromosome setup. You can analyze everything accurately. You can analyze because you are taking entire content, entire blastomere, the cell from the embryo itself, and we are testing. So that is always better. And double or triple marker, whether it is competent to that or what is the question, I couldn't understand. But if it is about the comparison you're asking, yeah, that is preferably better.
So the next embryology webinar will be on 9th March 2024. Now, GGIRHR is open for admission for the courses, both online and offline, which we also provide certain short-term research internship program. Finally, I would like to conclude today's CME. I extend my heartfelt gratitude for speakers in giving us an opportunity in getting a clear vision towards building up a career as clinical embryologists. I also thank all the participants in making today's webinar a successful event. Kindly contact GGIRHR for further course details on institutional fellowship in clinical embryology and PGDCE course, which is open for admissions. Thank you all.